Hello? Hello?
Yes. Okay. Okay.
Hello?
Okay. Yes. Okay. Okay.
Hello?
Hello. Am I audible? Yes. Hello. Okay. Okay.
Hello?
Hello. 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 Audible? Yes. Hello. Okay. Okay.
Hello?
Hello. 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 Audible? Yes. Hello. Okay. Okay.
Hello?
Hello. 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 Audible? Yes. Hello. Okay. Okay.
Hello?
Hello. Hello. At the outset, I wish to thank IMA Medical Student Network for having made this talk possible, and during difficult times. Okay. 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 So at the outset, I wish to thank the Indian Medical Association Medical Students Network for having made this possible. Okay. So when Kiran asked me to decide on the topic, I chose this topic for the simple reason that nearly 20% of your exam questions are from this chapter. So before I start, I would like all of you to do one thing. If you are viewing this stream on your laptop or on your desktop, I will advise you to view it at the highest resolution possible, because I am transmitting at 4K. And number two, I will like you to take your mobile, Android mobile if possible. Android mobile is ideal. You just install a QR code reader, because towards the end of the session, I'll be giving you 3 QR codes. All you got to do is scan those QR codes. You will get 3 ebooks which will be running from your Android mobile phones. One ebook is for undergraduates, the other ebook is for postgraduates, the third one is the most important of all, which covers the instruments in otolaryngology. Now let us jump directly to the topic. So here, one thing you will be finding unique here is I'll be using not the regular slide methodology for teaching. This is actually mind mapping. I'll be using bar diagrams to help to get over my points. So here, chronic otitis media is actually defined as chronic inflammation of the mucosa of the medullary cleft and the mastoid cavity. So by the term medullary cleft, we include the mucosal lining of the medulla proper, mastoid cavity mucosal lining as well as the mucosal lining of the eustachian tube. And these patients, they present with recurrent ear discharge via the tympanic membrane perforation. But mind you, the most important point I would like to stress is absence of perforation or intact eardrum does not rule out chronic otitis media. I repeat again, intact eardrum does not rule out chronic otitis media. But here in yellow, I had given out one point, which is actually what we were taught. We were taught that you will have to diagnose chronic otitis media only and only if there is a perforation or retraction in the attic or in the past tensor portion of the eardrum. But here the entire definition got changed 5 years back. And chronic otitis media can be precipitated by recurrent episodes of acute infection. It can be with or without eardrum perforation. And then whenever the medullary cavity is infected, inflamed, or eardrum is perforated, a sincere attempt is made by the body to repair it. And the attempts to repair starts with formation of granulation tissue. The granulation tissue is actually a vascular granulation tissue, and then it could be a oral polyp, a reparative oral polyp, or sometimes osteotic bony reactions. So either of these three things can occur as a reparative process. But mind you, when the medullary infection gets outside the confines of the medullary cavity, it creates complications. I repeat again, when the infection from the medullary cavity gets outside the confines of the medullary cavity, it leads to dreaded complications. Now, let us go to the histological aspects of chronic otitis media. Histologically, there is very little to differentiate between chronic otitis media and acute otitis media. In fact, the initial changes are almost the same. But what happens is the continuing inflammation leads to submucosal infiltration of histiocytes, lymphocytes, and mononuclear cells. And mind you, there is also increase in the vascularity of the medullary with associated proliferation of the goblet cells, which are known to secrete mucus. And chronic inflammation, in fact, leads to bony reactions, osteitis, bone destruction around the medullary cleft. Now, before I go to the pathophysiology, I like to take you down on a memory line that's saying that the medullary cavity is lined by three different types of epithelium. I repeat again, the medullary cavity is lined by three different types of epithelium. The attic or the epitympanum is lined by pavement epithelium. The medulla proper, mesotympanum, is lined by cuboidal epithelium, and hypotympanum, which is a continuation, superior continuation of the eustachian tube, is lined by ciliated columnar epithelium. So we are contented with three types of epithelium in the medullary cavity. So this three different types of epithelium has got three different types of reactions as a safeguard against infections and inflammation. For example, if the inflammation begins in the hypotympanic area, the ciliated columnar epithelium, the initial reaction is to dilute the effect of the toxin or bacteria by increasing the secretion of mucin. So there is active proliferation of the mucinous glands or goblet cells, and these patients have extensive mucinous discharge. So if the patient is going to present to you with mucinous profuse discharge, you can confidently say the infection has involved the hypotympanum. But when it comes to the medulla proper, what happens is the medulla proper is lined by cuboidal epithelium. The reaction of cuboidal epithelium to the inflammatory process or the irritant stimulus is to add layers on its own to become thicker and thicker, so that it will be able to withstand the insult. So when it starts to add layer to itself, when it starts to increase in its thickness, it becomes polypoidal in nature. So oral polyp is a classic feature of inflammation involving the medullary cavity proper. I have already told you now, the attic area or the epitympanum is lined by pavement epithelium. So the reaction of pavement epithelium is totally different from the other two types of epithelium I already told you. The pavement epithelium starts to granulate in response to inflammation. So granulation tissue are commonly seen in infections involving the attic region. Attic pathology is always has a tendency to granulate. With this small introduction, I like to go to the histological evidence of chronic otitis media, where let us go to the pathophysiology. Pathophysiology is conditions actually due to earlier episodes of acute otitis media. Chronic otitis media is actually most likely to be caused by earlier episodes of acute otitis media. And then persistent negative middle ear pressure can also predispose to chronic otitis media. And otitis media with effusion again can predispose to chronic otitis media. I've already told you infection spreading outside the confines of the middle ear cleft can lead to various complications. Let us see a little bit of the reparative process. I've already told you the chronic otitis media, the reaction of the ear is to repair itself. The preliminary reparative process include formation of vascular granulation tissue. So vascular granulation tissue's attempt is to fill up the dead space. Whenever there is erosion in the middle ear cavity, whenever there is bony destruction, the first reaction of the body is to fill up that space. And that filling up is done by formation of granulation tissue, which is highly vascular in nature. The second one is this new bone formation. So what happens whenever there is a bony erosion due to the presence of inflammation or cholesteatoma? There is osteotic reaction. Ultimately, this reaction leads to new bone erosion and new bone formation. So let us see these two processes in detail. Let us go to the granulation tissue process. Meyerhoff actually reported that granulation tissue develops in nearly all the cases of chronic otitis media, and in fact, it involves the most commonly the attic region or the epitympana. And it takes just a couple of days for granulation tissue to develop. And you should also remember granulation tissue is actually formed by immature connective tissue, and it is lined by immature capillaries, budding capillaries. And macrophages are known to infiltrate into this zone and known to release inflammatory mediators. Common areas involved by granulation tissue are attic region, round window niche. And formation of granulation tissue, what it does is, if it blocks the Otitis, actually the mastard air cells gets aerated via the middle ear cavity. So the mastard air cells needs the intact communication via the Otitis to the middle ear cavity for its ventilation. The ventilation of the air cells of the mastard cavity is from the middle ear cavity, and ventilation of the middle ear is via the eustachian tube. And eustachian tube communicates air from the nasopharynx into the middle ear cavity. So this is actually a picture showing presence of granulation tissue. If the granulation tissue is pale in color, you should always suspect tuberculous otitis media. I repeat again, a pale granulation tissue, you should always suspect tuberculous otitis media. This is actually a commonly asked questions in your clinicals. Whenever you report a granulation tissue, they'll ask you what exactly you will suspect if there is a pale granulation tissue. And here I am going to show you a video clipping which shows here the eardrum is totally perforated. The pars tensa is totally perforated. The ossicles are not seen. Here this is actually the eustachian tube opening. This is actually the middle ear opening of the eustachian tube inside the hypotympana. Here you see granulation tissue filling the attic area. This is the granulation tissue filling the attic area, and here crusting is seen due to dried up secretions. Now here the next type of reparative process actually is new bone formation. So osteoitis actually is inflammation of the osteoclastic bone resorption. So whenever bone gets eroded or resorbed, there is actually osteoclastic activity. These cells are known to cause bone erosion. So this erosion occurs in the ossicles, it can occur in the aortic capsule, it can also occur in the mastoid bone. So the ongoing osteitis and bone resorption and new bone formation, what they form is when these three combine together, they form a unique dense mastoid bone. So in this CT scan, this is a normal well aerated mastoid cavity. Here you see the air cells are replaced by homogeneous opacity. Here the mastoid air cell system is totally osteitic reactions has eroded the mastoid air cell system and new bone formation has taken over, and the mastoid bone itself has become dense and sclerotic. So here there is sclerosis of the mastoid. Here this is a normal pneumatization. So whenever you are confronted with this CT image, you can always say that this patient would have suffered from chronic otitis media sometime in their life. Now let us go to the etiology. So here, most common etiological factors which are involved in the pathogenesis of chronic otitis media are childhood acute otitis media or otitis media with effusion. Both these problems can cause long-term changes in the eardrum. So what can happen is the eardrum is supposed to have three lining type of tissue. It is outer portion of the eardrum which faces the external aortic canal is lined by squamous epithelium. The middle layer is fibrous in nature and the inner layer is lined by middle mucosa. So the middle eardrum is lined by three layers: the outer squamous layer, middle fibrous layer, inner mucoid layer. So the middle fibrous layer is invariably damaged. The middle fibrous layer is invariably damaged due to chronic otitis media. So there is actually a thinning of this membrane. So the three-layer membrane due to the chronic otitis media becomes a two-layer one, dimeric membrane. So a three-layer membrane, I repeat again, becomes a two-layer membrane, dimeric membrane, because of the loss of middle fibrous layer. This dimeric eardrum loses its ability or tensile strength. So what happens is it retracts in response to middle negative pressure. So pars tensa portion of the eardrum has, I repeat again, pars tensa portion of the eardrum is lined by three layers: the outer squamous, middle fibrous and inner mucoid. So in response to chronic otitis media, the middle fibrous layer is damaged. So damage to the middle fibrous layer, what happens is it causes thinning of the eardrum, or in other words, this is known as a dimeric eardrum. So this thinning, the weakening of the eardrum causes retraction of the eardrum medially in response to negative middle ear pressure. If middle ear pressure becomes negative, this type of dimeric eardrum retracts. On the contrary, the eardrum which covers the attic region or epitympanum has got only two layers. The fibrous layer is absent in the eardrum covering the attic region or the epitympanic region. So actually that area of the drum is inherently weak. So that area of the eardrum has immediate tendency to retract in response to negative middle ear pressure. Second common cause of chronic otitis media is eustachian tube dysfunction. Eustachian tube dysfunction can cause impaired ventilation of the middle ear cavity, leading on to persistent negative middle ear pressure, leading on to formation of retraction. Then gastroesophageal reflex disorders are known to cause chronic otitis media because in patients the middle ear fluids, when they analyze the middle ear fluids, they were able to isolate pepsinogen. Pepsinogen could be isolated from the middle ear cavity of patients suffering from chronic otitis media. So they are suspecting that probably pepsinogen can cause a smoldering infection of the middle ear mucosa due to gastroesophageal diseases. Hello? Tell me. No, at the end of the session, I mean, since it's a uni directional one, we'll at the end of the talk, I will take questions. I will scroll and reply. You just keep track. At the end of the lecture, I will answer all those questions. Okay. So I will answer all your questions at the end of the lecture. I will scroll and answer all your questions, type out all the answers, because I'm noting down all your questions. Since it's a unidirectional communication, just hold on. So next is immune deficiency and autoimmune disorders again can predispose to chronic otitis media. Then another important predisposing factors happens to be craniofacial abnormalities, where patients with cleft palate, they have an increased preponderance or increased risk of chronic otitis media. This really happens because of the inherent eustachian tube dysfunction. Why eustachian tube dysfunction is common in these patients? It is because of the abnormal insertion of the tensor valeae palatini muscle in these patients. Then recurrent episodes of upper respiratory infection can predispose to chronic otitis media. Then genetic and environmental causes also can cause chronic otitis media. And let us go one by one. Acute otitis media with effusion. Here, this can cause long-term changes in the eardrum. I have already told you histologically the eardrum has 3 layers. The middle layer is more susceptible to injury because it is less vascular. And what happens is, in patients with acute otitis media with effusion, the middle fibrous layer gets degenerated and loses its integrity. In these cases, what happens is elastic property of the eardrum is lost. So these patients are more susceptible for development of chronic perforation or chronic retraction. Let us go to the genetic and environmental causes of chronic otitis media. Actually, the incidence of chronic otitis media, it varies in different populations. The role of genetic factors is really very difficult to elucidate because currently so many gene studies are going on, but they have not been able to pinpoint the exact gene which is creating the problem. And pollution again is another factor which is slowly getting into the realm of science. And then incidence of URI again has got a huge role in the pathogenesis of chronic otitis media. And mind you, when it comes to pollution, I should tell you that when exposure of diesel fumes compromises the integrity of the ciliated columnar epithelium lining of the eustachian tube and the hypotympanum, preventing the drainage of the normal drainage function and normal clearance of the medullary cavity via the nasopharynx. And smoking again, be it active or smoking, be it passive or active, they cause damage to the cilia of the epithelium. Now, nasal allergy again, it predisposes to nasal block and eustachian tube dysfunction. Let me come to the pathological aspects of chronic otitis media. I've been already stressing about the role of acute otitis media as well as otitis media with effusion in the pathophysiology of chronic otitis media. So active chronic otitis media is actually chronic inflammation of the medullary mucosa, which should last for more than 3 weeks duration. When you want to say that some disease is chronic, the duration of the disease should be a minimum of 3 weeks duration, and discharge also should be there. And otitis media with effusion actually causes a lot of problem in children, because innocuously the speech gets delayed in these patients because they have conductive hearing loss because of the loss of middle fibrous layer of the eardrum. And molecular biological studies reveal hypoxia to be one of the most important factors, biological factor involved in the chronicity of the chronic otitis media. Here, this hypoxia in the medullary cavity induces hypoxia inducible factors, and this hypoxia inducible factors keeps the medullary inflammation smoldering. It activates the B cells, and this keeps the inflammatory process going, and it activates interleukin 1, it activates angiogenesis factor, then it activates tumor necrosis factor. So these factors play a vital role in continuing the medullary infection. Now, what are all the histopathological features of chronic otitis media? They are formation of granulation tissue, formation of cholesterol granuloma, formation of cholesteatoma, formation of osteitis or newborn formation. Now let us go to the factors involved in the pathogenesis of chronic otitis media. This is actually a multifactorial disorder. The factors which really play a role in the chronicity include innate immunity, adaptive immunity. Adaptive immunity is nothing but immunoglobulins. Then non-specific barriers, namely the epithelial barrier and mucin production. Then regulation of inflammation. Last but not the least, craniofacial abnormalities. Let us see one by one. The innate immunity. Innate immunity is actually contributed by toll-like receptors. In fact, toll-4 receptor responds and recognizes the lipopolysaccharide of gram-negative bacteria, and this is commonly seen in the medullary cavity. And this is actually the first line of defense against chronic otitis media, because gram-negative organisms are known to cause chronic otitis media. Next comes cytokines, and last but not the least is surfactants. So the innate immunity is created or provided for by 3 factors. One is toll-like receptor, toll receptor 4. The next is the cytokines. Third is the surfactants. So toll-4 receptors I've already told you. Next comes the cytokines. Cytokines are actually low molecular weight proteins. They are highly soluble and they are produced in response to antigen. For cytokines to be produced, antigen should be presented, and they function as chemical messengers. So they regulate both innate as well as adaptive immunity. So without cytokines, both adaptive as well as innate immunity are not going to function. And mind you, adaptive immunity depends on cytokines, and cytokines are generally secreted by helper T cells. Cytokines are generally secreted by helper T cells. Now let us come to surfactant. Surfactant proteins are two in nature. One is type A, surfactant protein type A. Another one is surfactant protein type D. And they are responsible for innate immunity because they bind and agglutinate to variety of bacterial proteins, allergen. And as soon as they are agglutinated, your macrophages swallow them, phagocyte them. Now let us go to the chronic otitis media subtypes. Actually, this is the current classification which is being followed. This classification is in vogue only for the past 5 years. So when we were students, we used to be taught in very simple terms, chronic otitis media is of 2 types. That's the previous classification which I am narrating, because you should also know this, because almost all of your examiners could be majority of your examiners will be from old generation, and they are more fond of the previous classification. So what is the old classification? We used to previously classify chronic otitis media in a very simplistic way, that is unsafe and safer. So what exactly you mean by unsafe? Whenever chronic otitis media has a propensity to cause complications, whenever the chronic otitis media has got a propensity to cause complications, it is termed as unsafe here. Whenever the chronic otitis media is not known to cause intracranial or other complications, it is known as safe here or safe CSOM. So in other words, safe ear is otherwise known as tubotympanic disease. Safe ear is otherwise known as tubotympanic disease. The unsafe ear was known as anticoantral disease. So all cholesteatoma was classified as anticoantral disease, and all discharging ear with involvement of the pars tensa are termed as tubotympanic disease. So as a rule of thumb, they expected tubotympanic disease to be safe and anticoantral disease to be unsafe. But actually the demarcating line between the safe and unsafe is slowly weeding off, and the subtypes chronic otitis media is being reclassified under 5 heads. One is the active mucosal component, the next is the inactive mucosal, the third is the active squamosal, fourth is the inactive squamosal, and fifth is the healed type. So let us go to number 1, active mucosal. So in active mucosal type of chronic otitis media, there can be a perforation in the pars tensa portion of the eardrum with discharge, purulent discharge, as shown in this picture. Or I have already told you, if the middle ear proper gets involved by inflammation or infection, polyp formation occurs. Here you are seeing a oral polyp. So presence of oral polyp or a mucopurulent discharge in the middle ear cavity is a feature of active mucosal disease. Now let us come to inactive mucosal disease. Here, in an inactive mucosal disease, the middle ear is not inflamed. I repeat again, in inactive mucosal disease, the middle ear is not inflamed. Here you see a large central perforation. You see a large central perforation with normal middle ear mucosa, pale normal middle ear mucosa. If you watch the rim of the perforation, along the rim of the perforation, the outer squamous lining of the eardrum and the inner mucosal lining of the middle ear cavity, they have merged along these lines. So the merger of the outer squamous and the inner mucous layer prevents the reepithelialization of this defect. So this defect is not closed for the simple reason that the outer squamous has merged with the inner mucosal lining. So these patients have a persistent perforation. Of course, they have a dry ear, but they will have definitely hard of hearing. Conductive hearing loss will be there. So since we are having a large perforation through which the middle ear cavity is seen, I take this opportunity to describe some of the contents of the middle ear cavity. So middle ear's most important content, of course, is the presence of air. So air I cannot display here, but here this one is the handle of the malleus. This is the handle of the malleus. This is the lateral process of the malleus. This is the long process of the incus. This is the long process of the incus. This is head of the stapes. My cursor is now pointing towards the head of the stapes. This is the foot plate of the stapes. This is the round window niche and round window. This is the round window niche and round window. This is the promontory. This is the promontory. So here in inactive mucosal pathology, the middle ear mucosa is not inflamed. It is normal and pale in color. Let us go to active squamosal. Here pathology of active squamosal component of the chronic otitis media, you call it cholesteatoma. And cholesteatoma, previously they used to classify it under 2 heads. One is the congenital cholesteatoma, the other is the acquired cholesteatoma. Now mind you, the term congenital cholesteatoma is being questioned now. I will tell you why later. And the basic pathogenesis of cholesteatoma, according to some people, is actually the retraction of the Sharpnell's membrane. Sharpnell's membrane is nothing but the portion of the tympanic membrane that covers the attic region or the epitympanum. I have already told you the portion of the eardrum which covers the attic region does not have the middle fibrous layer. Hence, this portion of the eardrum is weak and it is known to cause retraction, known to get retracted into the middle ear cavity in response to persistent negative middle ear pressure. So this retraction pocket is the first phase of cholesteatoma development, and then into this pocket the epithelium from the external artery canal, squamous epithelium from the external artery canal gets desquamated, it fills this sac. So cholesteatoma is actually defined as a benign cystic lesion. Benign cystic lesion, which is a sac-like structure, which is covered by keratinizing stratified squamous epithelium, and inside which are the cellular debris containing squamous cell, desquamated squamous elements. So this cholesteatoma is actually termed as skin in wrong place. The crude way to define cholesteatoma is skin in wrong place. The skin, as you all know, is lined with squamous epithelium. So inside the mid layer cavity, where mucosal lining should be there, if skin is present, it is cholesteatoma. Squamous element is nothing but skin. So crudely they call it skin in wrong place. Actually, the term cholesteatoma was first coined by Jonas Muller, and the currently accepted theory of cholesteatoma happens to be the basal cell hyperplasia. What happens is the basal layer of the squamous epithelial lining of the temporal tympanic membrane, they proliferate and somehow breaches the barrier of the annular ligament and spreads into the mid layer cavity. So even though the term congenital cholesteatoma is slowly being taken away because people don't accept this diagnosis, but still, for the sake of completion, I need to speak about it. Here, these are various theories, but before elaborating on these theories, I would like to lay down certain criteria for diagnosing a patient to be suffering from congenital cholesteatoma. These criteria were actually first laid down by Levinson. So obviously it is known as Levinson criteria for diagnosis of congenital cholesteatoma. Here, according to Levinson's criteria, the first criteria should be there should be a whitish mass behind an intact membrane, intact eardrum. See, you see the whitish mass behind an intact normal eardrum. There is no perforation. The pars flaccida and pars tensa should be normal. And these patients should not have had prior history of eardrum perforation or otorrhea. Again, the fourth criteria should be these patients should not have undergone any previous ear surgery. So these are all the prerequisites which needs to be fulfilled before you can diagnose a patient with congenital cholesteatoma. But mind you, currently the fifth criteria which Levinson said, no history of prior inflammation of the mid layer cavity. So that has been taken away. So mid layer infection is rather common. So they don't want to include it for the under the Levinson criteria for diagnosing congenital cholesteatoma. So mind you, there are various theories have been proposed to account for this congenital cholesteatoma. Teed's epithelial cell theory, Friedberg's implantation theory, Rudy's invagination theory, Amy's epithelial migration theory, and Michael's epidermide formation theory. So according to Teed, he said persistence of the squamous cellness according to Teed are present in the temporal bone in various areas, and they proliferated and they developed cholesteatoma. So obviously cholesteatoma is nothing but squamous cell rest. So these squamous cell rests which are already present in the temporal bone proliferates and forms cholesteatoma. Then invagination theory of Rudy suggests that the intrauterine infection of the fetus, it causes retraction of the eardrum. Mind you, the fetus has a completely developed ear by the third week of intrauterine life. So a fetus is actually the first sense organ to develop in a fetus is hearing, ability to hear. So according to Rudy, the neonatal infection of the mid layer cavity led to retraction of the pars tensa portion of the eardrum, causing invagination, predisposing to cholesteatoma formation. Friedberg, he said, when he studied the amniotic fluid in a routine manner, he found squamous elements inside the amniotic fluid. So he suggested that these amniotic fluid could have been aspirated by the child. The child usually keeps swallowing the amniotic fluid since it is floating in it. So what happens is this squamous element will somehow find its way into the mid layer cavity via the eustachian tube. So they can proliferate. But this again, these theories are all very far-fetched because normal squamous epithelium, they are not carcinogenic. They cannot get knighted into some area and starts to multiply. So these are all imagination of well-founded scientists. So AIIMS theory, he says that the ectoderm of the external aortic canal, ectodermal lining of the external aortic canal, or the skin lining of the external aortic canal, somehow migrates into the medullary cavity, overcoming somehow the restraining effect of the annulus. Annulus is one structure which prevents the epithelial migration from the external aortic canal into the medullary cavity. And mind you, if the annulus is destroyed or if the annulus is absent, I repeat again, if the annulus is destroyed or the annulus is absent, external ear skin lining can jolly well proliferate and get into the medullary cavity. So that is nothing but cholesteatoma, skin in the wrong place. So naturally speaking, annulus is absent in the aortic region. I repeat again, naturally speaking, normally annulus is absent in the aortic region. So that is why aortic region is more commonly involved in cholesteatoma rather than the past tense mesotympanum or hypotympanum. So the cholesteatoma invariably begins in the aortic region because of the lack of middle fibrous layer in the aortic. So mind you, this congenital cholesteatoma invariably originates from the anterior superior quadrant. Then it travels to the posterior superior quadrant, and then it travels to the Otitis into the mastoid cavity. That's how it moves. So these are all various theories, and mind you, currently the term congenital cholesteatoma is being questioned now. I'll tell you why. Now let us go to the features of acquired cholesteatoma. Acquired cholesteatoma in fact is subclassified into primary acquired and secondary acquired. So the primary acquired cholesteatoma, the most important causative reason for this primary acquired cholesteatoma happens to be inflammation of the middle ear and not the retraction pocket alone. I repeat again, the most common pathophysiological mechanism causing primary acquired cholesteatoma happens to be inflammation of the medullary cavity rather than retraction. In fact, the precursor for cholesteatoma in the medullary cavity is inflammation and not the retraction pocket. That should be stressed and re-stressed. And then secondary acquired cholesteatoma is actually caused by acute necrotizing otitis media. So this acute necrotizing otitis media is commonly seen in children with measles. So children with measles have depressed immune reaction and they are more prone for inflammations involving pneumococcus type 3 organism. So this pneumococcal type 3 organism, it is highly destructive in nature. So it destroys the entire eardrum, middle mucosa along with the annulus. I've already told you, if the annulus gets destroyed, there is nothing to stop the squamous epithelium from the external aortic canal to move into the medullary cavity. So that is the reason why secondary acquired cholesteatoma is happening. And then this cloud will help you to understand why congenital cholesteatoma, the term is not held valid these days. So recently, when they started studying the cell migration pattern, they found out that the cholesteatoma formation always occurred from the squamous element of the eardrum. So, squamous epithelium of the eardrum only causes cholesteatoma and not the squamous lining of the external aortic canal. So, the epithelial migration studies, they revealed that cholesteatoma is always formed by squamous elements from the eardrum and not from the external auditory canal. So that is the reason why they accounted for this congenital cholesteatoma is not an entity. This cholesteatoma is actually formed by these squamous cells from the lining tympanic membrane, which gets into the medullary cavity, overcoming the restraining influence of the annulus. Now, you can also classify cholesteatoma according to the topology. Topology means where it arises. So it can be attic cholesteatoma if it involves the attic alone, when there is a retraction pocket and then mixture of squamous element gets retained due to papillary proliferation. So attic area, when it gets involved by cholesteatoma, it is known as attic cholesteatoma. If the pars tensa area is retracted and gets adhered to the medullary cavity and forms cholesteatoma. It is called pars tensa cholesteatoma. Here, cholesteatoma can involve the tympanic orifice of the eustachian tube. So, in pars tensa cholesteatoma, tympanic orifice of the eustachian tube is blocked. And then the third topological classification of cholesteatoma include sinus cholesteatoma, where this involves the sinus tympanic portion of the medullary cavity. So, in all patients with retraction pocket involving the posterior superior quadrant, mind you, in all patients with retraction pockets involving the posterior superior retraction pocket or perforation of the pars tensa, they extend into the tympanic sinus and they end into the posterior tympanum and goes travel posteriorly. That is the sinus cholesteatoma. And then theories. There are again 5 theories which have been proposed to account for the pathophysiological mechanism of primary acquired cholesteatoma. One is the Karthikeyan theory, next is the Tumartin theory, third is the TOS theory of invagination, fourth is the Wendt metaplastic theory, fifth is Haberman's epithelial invasion theory. We will see these theories one by one. Here, let us come to the Karthikeyan theory. Actually, Karthikeyan suggested that cholesteatoma actually originated from the congenital embryonic cell rests. These cell rests were identified all over the temporal bone. When they did a cross-sectional histopathological study of the temporal bone, they found these cell rests, squamous cell rests, in almost 16 areas of the temporal bone. So, according to Karthikeyan, he suggested that these cell rests somehow, instead of becoming dormant or becoming stable there, could have led to proliferation and can cause cholesteatoma. Next comes the Tumartin theory. Tumartin believed that cholesteatoma actually occurs due to migration of squamous epithelium from the deep portion of the external aortic canal into the medullary cavity. But mind you, there is a barrier for this movement, movement of squamous epithelium from the external aortic canal to the medullary cavity, namely the annulus. So, for this barrier to be lost, say this can be lost only in marginal perforation or total perforation of the eardrum. So, what exactly you mean by total perforation of the eardrum? The total perforation of the eardrum indicates total loss of tympanic membrane along with the annulus. I repeat again, total perforation of the eardrum indicates total loss of eardrum along with its annulus. So, in total perforation and in marginal perforation, the annulus is totally lost and there is nothing to stop migration of the squamous epithelium into the medullary cavity. Next comes TOS theory. TOS actually postulated persistent negative pressure in the medullary cavity can cause the invagination of pars flaccida, thereby forming a retraction pocket. This pocket actually becomes filled at a later date by desquamated epithelial debris. And these epithelial debris, they form a nidus for later bacterial infection. Next comes the Wendt theory. Wendt actually said that attic, I have already told you about the differences in the mucosal cells lining the medullary cavity, various areas of the medullary cavity. I have told you that attic portion or epitympanum is lined by pavement epithelium, and this pavement epithelium has got a unique way of responding to insult, that is forming granulation tissue. That is exactly what Wendt told. Now let us come to various retraction pocket in the pars flaccida. So the pars flaccida retraction pocket have been classified or graded into 4 types. Here is the type 1, TOS type 1 retraction. Herein the retraction is there, but it is not in contact with the neck of the malleus. This is the neck of the malleus. The retraction is there. This is the retraction pocket. This has not touched the neck of the malleus. In grade 2, what happens is this retraction pocket has touched the neck of the malleus. This is the scutum or the outer attic wall. This is the scutum or outer attic wall. Now, TOS 3, grade 3 TOS retraction. Here in grade 3, in addition to what I have told in grade 2, there is minimal erosion of the outer attic wall. Here you see the minimal erosion and the sac is touching the neck of the malleus. Say Then here you see the erosion, sac is touching the neck of the malleus. This is grade 4. Grade 4, there is total erosion. The large portion of the outer attic wall is eroded and the sac is enlarged and it clothes the neck of the malleus. So how are we going to identify? There are necrotizing otitis media I have been telling in the previous slides. But there are certain unique features by which you can identify acute necrotizing otitis media. I have already told you it is caused by measles or erythematous fever. Then there is the perforation occurs rather early in the disease. So the patient will have at least 1 or 2 days of ear pain, and suddenly the entire pars tensa of the eardrum will be necrosed and gone along with the annulus. And mind you, the secretions will be devoid of mucin. The secretions will be devoid of mucin. It won't have any mucinous material. Discharge from the ear will be thin, foul smelling, and then it will be devoid of mucin. Type 3 pneumococcal infection has been implicated in these patients. So I am going to show you an interesting video. Here you have patient with total perforation. Here is attic perforation. Total perforation, I'll show you. I'll just pause and show you. Here the eardrum is totally perforated. Pars tensa is totally gone along with the annulus. So you don't see the annulus here. This is the handle of malleus. Here this is the attic region. The attic region is perforated. Here you see granulation tissue. Since we suspected tuberculosis in this patient, we went ahead and took a biopsy of the lesion and it turned out to be tuberculosis. It's very rare nowadays for getting tuberculosis infection in the midlear cavity, even though tuberculosis is common. So by UC biopsy being taken. Let us come to inactive squamous cell. Sir, inactive squamous cell, what happens is the pars tensa can be totally adhered to the promontory. Then pars flaccida also can be totally adhered to the promontory. All you have is a retracted eardrum. So the retracted eardrum will be close to the midlear cavity. Here you see the prominent handle of the malleus. What are all the classic features of the retracted eardrum is the prominence of the hand of the malleus. And you can see the handle of malleus being pulled medially. It is pulled medially towards the promontory. So this causes apparent shortening in the length of the handle of malleus. So there is apparent foreshortening of the handle of the malleus. Then here you see the lateral process which is really prominent. So the third point to indicate retraction of the eardrum is prominence of the lateral process of the malleus. And then if you segalize, the drum will not move. If you segalize, drum will not move. So the last but not the least is the entire medullary mucosa will be replaced by squamous epithelium, and there won't be any debris. The entire medullary mucosa will be replaced by squamous epithelium. So this is known as epidermization of the medullary cavity. I repeat again, when the entire medullary mucosa gets replaced by squamous epithelium, it is known as epidermization of the medullary cavity. That is actually a safe thing to have, and the entire infection and inflammation have subsided. It is actually a burnt out phase of the disease. So I wish to repeat what are all the clinical features of retraction of eardrum. This is one of the common questions asked in your case presentation. So the number one feature happens to be foreshortening of the handle of malleus, or apparent foreshortening, because the handle of malleus is pulled inwards. So when it gets pulled inwards, when you do otoscopic examination, it looks as if it has been shortened. So there is apparent foreshortening of the handle of malleus, and then the lateral process of the malleus is again prominent. And then you look into the malleolar folds. Anterior and posterior malleolar folds are really prominent. So the malleolar folds, the anterior and posterior malleolar folds are prominent, and then you see multiple retraction pockets. You see multiple retraction pockets. Then last but not the least is the eardrum will not move, and even if it moves, it will be sluggish in patients with retraction. So how do you test for mobility of the eardrum? You need to use a Siegel's speculum, or you can use a pneumatic attachment of your otoscope. Here I am showing you a very interesting video wherein the entire eardrum is retracted, totally plastered to the middle ear cavity. Now I have asked the patient to do a Valsalva maneuver. Let us see what happens when the patient does a Valsalva maneuver. He's going to do the Valsalva maneuver now. Watch carefully. See what happens. See the eardrum bulging out. This is actually a dimer. The middle fibrous layer is absent. This is a classic dimer. The outer squamous lining, the inner mucosal lining are there. The middle fibrous layer is lost. So when the patient is doing a Valsalva maneuver, you see the lower portion, the portion closest to the hypotympana, closest to the eustachian tube bulges out. The area closest to the eustachian tube bulges out. Here again, the other ear, you see what happens when the patient does. See, the area of the eardrum closest to the eustachian tube bulges. Even though it is retracted, this area is a dimer. Only two layers to the eardrum. There is no perforation. See the eardrum, the hypotympanic lining of the eardrum beautifully bulges in and out when the patient performs Valsalva maneuver. Now let us go to inactive squamous cell. This I think I have already finished. Sorry. Let us go to the healed one. So healed chronic otitis media. Here, this is a classic feature of healed chronic otitis media, where the eardrum, the middle fibrous layer is lost. Here you see a dimer. Here you see a dimer. Outer squamous, the middle mucosal layer are stuck to each other. So here is a dimer. Here is a dimer. These are two weak areas of the eardrum. So these areas again can retract or can reperforate. Can retract or can reperforate. So sometimes what happens is, even though the middle fibrous layer is lost, that fibrous layer is replaced by hyaline deposits. These hyaline deposits can later, they undergo calcification causing tympanosclerosis. This is actually classic tympanosclerosis. Tympanosclerosis occurs in the middle fibrous layer of the eardrum. So let us go to the features of the healed chronic otitis media. I have already told you the healed otitis media is a dimer. The outer squamous in the inner mucosal layer is there. Middle fibrous layer is lost. Tympanosclerosis occurs in the middle fibrous layer in some patients. This is actually a hyaline deposit of acellular material, which is actually visible as whitish flake-like material on otoscopy, and pathologically under microscope they are formed by thickened collagen fibers, both type 1, type 2 and type 3, and mixed with calcium phosphate crystals. So on prolonged duration, what happens at a later date, it could even ossify. If this tympanosclerosis involves ossicles, it can cause fixity of the ossicle, leading on to conductive hearing loss. Let me zoom out. Let us go to the complications of chronic otitis media. This is what we are most worried about. So the most common complication of chronic otitis media happens to be mastard abscess. For mastard abscess to occur, these patients should have a pneumatized mastard air cell system. For mastard abscess to occur, these patients should have a well pneumatized mastard air cell systems. And next common complication happens to be labyrinthitis, inflammation and infection of the labyrinth. And mind you, the prevalence rate of all these complications due to COM ranges between 0.5 to 5%. And the presence of granulation tissue as well as cholesteatoma are the most important features which lead to these complications, because cholesteatoma and granulation tissue has got a unique feature of bone erosion. They can erode the normal barriers, thereby causing the infection and inflammation to get up at the confines of the middle ear cavity. Then Next common complication of COM happens to be labyrinthine fistula. Labyrinthine fistula occurs when the outer bony covering of the labyrinth is eroded, and it is seen in nearly 4 to 13% of patients with acute and chronic otitis media. So what happens is, whenever the lateral semicircular canal, which is commonly involved in fistula formation, erosion occurs due to granulation tissue and cholesteatoma matrix. It can invade, it can erode the lateral canal, and it can come into direct contact with the endosteal lining. It can come into direct contact with the endosteal lining. The moment it comes into contact with the endosteal lining, there is initial irritation of the labyrinth. The patient will have giddiness, the patient would have vomiting, the patient would have mild tinnitus. So these are all the features which indicate that the labyrinth is slowly suffering. But there is a unique reparative mechanism available to the body here also. What happens is, these cholesteatoma matrix as well as granulation tissue, they seal the fistula, and the margins, osteotic margins, osteotic reaction taking place at the margin of the fistula will ossify and will even close the fistula spontaneously. So these patients, some of the patients, even in the presence of anatomical presence of fistula, may not have any clinical manifestation of the fistula for the simple reason the fistula would have been closed by the granulation tissue or cholesteatoma, and later ossification process closes it down permanently. Nature has got a unique way of repairing any damage. Now, I have been harping on the spread of infection from the middle ear cavity to the other areas. So, what are all the possible routes of spread? Some of the possible direct spread occurs when the disease manages to erode the tegment tympani. Tegment tympani is actually the roof of the middle ear cavity, which separates the middle ear cavity from the middle cranial fossa. So this erosion can occur as a result of acute infection, or can occur as a result of erosion by cholesteatoma, or can occur due to the famous osteotic reaction of chronic otitis media. And then the next way of spread can occur via the venous channels. So what happens is, infected clot from the small veins through the bone and the dura can get into the large sinuses. So thrombophlebitis of the lateral sinus or the sigmoid sinus can lead to cerebellar abscess. I repeat again, lateral sinus thrombosis can lead to cerebellar abscess. Similarly, superior petrosal sinus thrombophlebitis can lead to temporal bone abscess. And this is one of the common multiple choice questions which is asked. So, thrombophlebitis involving lateral sinus, I repeat again, thrombophlebitis involving the sigmoid sinus or lateral sinus, both are the same. They spread to the cerebellum directly, causing cerebellar abscess, and then thrombophlebitis involving the superior petrosal sinus can spread into the temporal lobe of the brain. Then the third way, infection from the middle ear cavity to spread outside is via the normal anatomical pathways. Mind you, the middle ear cavity is not a totally closed cavity. There are normal openings available. So the common openings which are seen in majority of the cases include oval window, round window, internal artery meatus. These are almost seen in 100% of the patients. And then in a good proportion of the patients, there could be a dehiscence of the bony covering over the jugular bulb. Anatomically, you will be knowing that the jugular bulb forms the inferior relationship with the tympanum, middle ear cavity. So the low floor of the middle ear cavity is related to the jugular bulb. It lies just over the jugular bulb. In some patients, this floor may be found wanting. There may be dehiscence of the bony covering of the floor of this area. So the jugular bulb will be exposed to the middle ear cavity. Then spread of infection can occur through non-anatomical defects. So what are all the possible non-anatomical bony defects that can occur? There can be a fracture line. So if the patient would have sustained temporal fractures, the fracture line will be there. So infection can spread via the fracture line. Sometimes presence of neoplasia can cause erosion and can destroy the bony barrier. And then surgically, deliberately, a surgeon could have created defects, surgical defects in the temporal bone. The commonly performed surgery to create a defect in the temporal bone is the stapedectomy surgery, where the surgeon artificially creates an opening into the oval window and closes it arbitrarily with a piston. So this is surgically created defect is surgery of stapedectomy. So infection, middle infection in a patient who has undergone stapedectomy is dangerous because infection can spread via the oval window, perforated oval window into the inner ear. And then spread, this is one of the unique way infection of the middle ear cavity can spread is via the spaces around the arterioles. It's known as periarteriolar spaces of Virchow-Robin. So spread of infection via the Virchow-Robin spaces can directly involve the white matter without touching the gray matter of the brain. Repeat again, spread of infection from the middle ear cavity via Virchow-Robin periarteriolar spaces can directly cause infection to involve the white matter, skipping the gray matter. So this is one unique way infection can spread into the directly into the white matter of the brain without touching the gray matter. So this is actually a diagrammatic representation of what all I have told you, the channels of communication between the middle ear cavity and outside through which infection and inflammatory process can permeate outside. Now, let us go to labyrinthitis. See, I am taking this opportunity to cover the entire topic of labyrinthitis because this is again commonly asked short notes. So, labyrinthitis is actually defined as inflammatory disorder involving the inner ear. And clinically, what happens is this causes disturbance of balance and disturbance in hearing to varying degrees. So let us see what are the probable causes of labyrinthitis. Labyrinthitis can be caused by bacterial infection, can be caused by viral infection, can be caused by autoimmune diseases, can be caused by vascular ischemic causes. Then let us go to the route of entry. So route of entry, how infective material or pathogen gets into the inner ear. I've already told you about the pre-existing fractures of the temporal bone, oval window, round window. So this round window membrane, permeability of the round window membrane increases in the presence of middle ear inflammation. So what happens is it permits the bacterial toxins to get to the inner ear. Increased permeability of the round window membrane permits the bacterial toxins to get into the inner ear. And then congenital lesions involving any portion of the bony labyrinth can also provide a route of entry. Now, viral labyrinthitis is a unique entity. This is actually characterized by sudden unilateral loss of hearing. These patients have sudden unilateral loss of hearing and they have unilateral loss of equilibrium. And these patients have vertigo, and this vertigo is really incapacitating in nature and it's associated with vomiting. And this vertigo again is self-limiting and it subsides within 1 to 1.5 months. And hearing loss, if you do a Puton audiometry, you will find it is confined only to high frequency and it is sensory neural in nature. And patient will invariably give history of attack of upper respiratory infection prior to the development of these symptoms. And this condition should be differentiated from vestibular neuronitis. I repeat again, viral labyrinthitis should be differentiated from vestibular neuronitis. How are you going to differentiate both of them? In vestibular neuronitis, cochlear nerve is spared, only the vestibular nerve is affected. So viral infection affecting the vestibular nerve causes vestibular neuronitis, and here only the vestibular nerve is involved. So these patients will have only balance disorders and hearing will be normal and intact. So in a patient with vestibular neuronitis, patient will have a normal hearing but will have giddiness. Whereas in viral labyrinthitis, the patient will have sensory neural hearing loss as well as giddiness. So these are the common viruses which have a propensity to involve the inner ear. These could be mumps, measles, rubella, and cytomegalovirus. Now, bacterial labyrinthitis actually causes irreversible damage to the labyrinth. So, bacteria can enter the labyrinth via the meninges. So, these patients, if they have childhood meningitis, bacteria can traverse the cerebrospinal fluid and get into the inner ear fluids, causing labyrinthitis. Then, otitis media can cause labyrinthitis by its propensity to erode the body inner ear. So, what happens is, if the patient is suffering from meningitis, if the child is common in pediatric age group, if the patient is suffering from meningitis, bacterial spread occurs via the CSF, it reaches the inner ear fluid through the internal auditory meatus or the cochlear aqueduct. Mind you, when it gets into the CSF, both ears are affected. So, in meningitis, the children will have bilateral dead ear because bacteria penetrates the CSF and involves both the ear. It penetrates the inner ear via the internal auditory meatus or via the cochlear aqueduct. So, labyrinthitis, bacterial labyrinthitis as a sequelae to meningitis is always bilateral, whereas bacterial labyrinthitis as a sequelae to otitis media is unilateral. That is one way of differentiating bacterial meningitis, bacterial labyrinthitis caused by meningitis or bacterial labyrinthitis whether it is caused by otitis media. And mind you, bacterial infection again can enter the middle ear, I've already told you, by erosion of the lateral wall or the promontory, by cholesteatoma or granulation tissue. And suppurative labyrinthitis always is followed by a reparative process. And the reparative process is nothing but ossification here. So these patients will have an ossified labyrinth. So these patients will have labyrinthine ossificant. They will have a totally dead labyrinth. And these patients need a cochlear implant for them to regain their hearing. So what are all the common organisms, bacteria involved in bacterial meningitis? Streptococcal pneumonia, Haemophilus influenza, Staphylococcus, Neisseria, Bacteroides, Proteus, Moraxella. There is one entity known as serous labyrinthitis. Serous labyrinthitis is actually a reversible disorder. This is actually caused by diffusion or permeation of the bacterial toxins into the inner ear via the increasingly permeable round window membrane. So these toxins cause reversible damage to the inner ear mechanism or inner ear functions. So how are you going to differentiate serous labyrinthitis from suppurative or purulent labyrinthitis? If the patient recovers from labyrinthitis fully, the patient has suffered from serous labyrinthitis. If the patient has not got back the hearing as well as the balance, the patient would have definitely suffered from suppurative labyrinthitis. So this is actually a diagnosis of whether he recovers the function. If he recovers the function, it is serous labyrinthitis. If the patient is not able to recover the function of hearing and balance, it is suppurative labyrinthitis. And the next important complication of chronic otitis media happens to be facial nerve paralysis. The incidence of facial nerve paralysis actually ranges, it's very wide range, 0.5 to 2.5%. But the presence of granulation tissue and cholesteatoma, they cause erosion of even the intact fallopian canal and cause facial nerve palsy. And in acute otitis media, if there is a dehiscence of the facial nerve in some portions of the middle ear cavity, the facial fallopian canal may be deficient, and particularly just above the oval window, it is commonly found to be dehiscent. So whenever the facial nerve is exposed to the middle ear, the inflammatory process involving the middle ear easily involves the facial nerve also. And if the patient is having cholesteatoma, then cholesteatoma matrix, as you all know, can erode the fallopian canal, causing facial nerve paralysis. The prognosis of facial nerve paralysis as a result of chronic otitis media is actually worse than when compared to that of Bell's palsy. Let us go to the other complication of chronic otitis media. These patients have hearing loss. The hearing loss may be conductive in nature because of perforated eardrum as well as damage to the ossicle, erosion of the ossicle. And then hearing loss can be sensory neural because of the involvement of the inner ear due to diffusion of bacterial toxin via highly permeable round window membrane. And then mixed hearing loss due to combination of both these factors. Now, let me go into the various factors that influence the activities of the chronic otitis media. So, how come these infections in the medullary cavity become chronic? Actually, nearly 60% of these patients, when they did a bacterial study, biofilms have been identified. I know you would have all heard about the concept of biofilm in your microbiology, but still I would like to go to the barebone basics of what exactly these biofilms are. Because these bacteria are known to exist in colonies, and if the different types of bacteria happens to reside in the same colony and they cover themselves with secreted mucopolysaccharides, they form a wall around them. So these are known as slimy biofilms. It is very difficult for drugs to penetrate this biofilm barrier, and bacteria, they live in a protected environment, creating enough havoc to the body. So they develop antibiotic resistance, and then antibiotics, in fact, on top of it, won't be able to get into the biofilms to target the bacteria. And then recurrent attacks of upper respiratory infection again can keep the medullary infection smoldering. And pus culture from all these patients was never negative. They really they were able to isolate gram-negative pathogens. There is one unique entity known as permanent perforation syndrome, wherein that is classified as inactive mucosal disease, where there is a dry central perforation. I have already shown you a picture with a normal medullary mucosa. So what happens is, these patients, they won't have any problem, but when the medulla gets gets exposed to infection via the external ear canal, when the patient is attempting to swim or dive, then they will have a attack of chronic otitis media. Now, let us go to the clinical examination. You all do a otoscopic examination. Before doing otoscopic examination, you should look behind the pinna for the presence of any incision. So, because post-oral incision of William Wilde is commonly used in Mastoid surgery. So, in order to rule out whether the patient would have undergone any Mastoid surgeries, you need to push the pinna anteriorly to look for evidence of scar in the post-oral area. That is what we should first see. And then examination under otoscopy will help you to diagnose these patients immediately. Then you should look for presence of open mastoid cavity. The mastoid cavity can be created surgically. The previous surgery could have created a cavity, or the disease process, cholesteatoma, would have caused a mastoid cavity. So you should look for presence or absence of mastoid cavity by pulling the pinna and straightening the external aortic canal relevantly to looking into the attempting to look into the eardrum. So eardrum, for sake of examination, is divided into 4 quadrants: anterosuperior, posterior superior, anteroinferior, posterior inferior. And mind you, our previous classification used to say all perforations of pars tensa are tuber-tympanic disease, and all pathology and perforations of the attic or epitympanum is supposed to be attico-antral. And mind you, annulus should be intact for prevention of migration of squamous element from the external aortic canal. The next thing you will have to rule out during the examination is whether the lesion or medullary pathology is active or inactive. So active lesion will always be associated with discharge. If the discharge is foul smelling, the foul smelling discharge always indicates presence of cholesteatoma. Why foul smelling discharge occurs in cholesteatoma? The classic smell is musty odor. So the old generation examiner will ask you, so what is the odor of cholesteatoma? It is actually a musty odor. This odor is caused by gram-negative organism generating hydrogen sulfide and other foul-smelling gases. Now let us go to examination on the table. Here, this examination is performed under microscopy. This is actually a gold standard in the diagnosis of CYN. It allows the examiner to manipulate the ear. The examiner can clean the ear, remove the wax, and can even suck out cholesteatoma flakes. Now, you can make nearly 90% accurate diagnosis based on the history alone. So 80% of the patients with chronic otitis media, they have hearing impairment. And nearly 70% have complaint of ear discharge. And mind you, history of foul smelling discharge always indicates squamous cell disease. Squamous cell disease is actually the new classification. You have divided the entire chronic otitis media into mucosal and squamous cell disease. Here, the presence of foul smelling discharge should be known to indicate squamous cell disease. And otalgia is commonly present in these patients. What are the causes of otalgia in these patients? Otalgia can be due to inflammation of the external aortic canal due to the presence of pus. So pus, when it comes into the external aortic canal, what a patient will be attempting to do, he'll attempt to clean the ear with the earbud. So repeated attempts of cleaning the ear with the earbud traumatizes the external aortic canal, leading on to otitis sectiona. So secondary otitis sectiona can occur in these patients, and then you should be very clear in eliciting previous history of ear surgery, and you should do the putaudiometry patiently to diagnose the type of deafness. Now, in all cases of otological examination, you should perform a fistula test. This test is actually performed to rule out fistula in the lateral canal. So, how we are going to perform fistula test? Grossly, you can apply positive and negative pressure by alternately pressing and releasing the tragus. By doing so, you will be applying pressure to the eardrum alternatingly. So if this happens, what happens when you apply pressure by pressing the tragus? The patient will have giddiness and nystagmus. The same thing you can achieve by using a pneumatic speculum attachment of the otoscope. When you press the bulb, after putting the speculum into the external aortic canal, you can see nystagmus, and then you can the patient will complain of giddiness. So fistula test is positive in patients with fistula in the inner ear, and in the case of fibrosis involving the vestibule. Then imaging, role of imaging, high resolution CT of the temporal bone is actually done to rule out intracranial complications. But still, you can assess the extent of the disease. In patients with cholesteatoma, CT reveals a lot. It tells you the status of the barriers of the bony barriers of the midline cavity. Then in HRCT, cholesteatoma appears as a homogeneous mass. And mind you, the density is more or less similar to that of a edematous mucosa brain tissue. And bacteriological and fungal cultures, actually, if you do it, it will help you in deciding the antibiotic. Let us go to the management. So, we have already classified the chronic otitis media into inactive mucosal, active mucosal, inactive squamous cell, and active squamous cell. So, let us see how we are going to manage each of these conditions. So, if the patient is going to have an inactive mucosal disease, so this is actually not a problem. You have various management options. The easiest thing is these patients they won't have discharge. The midlayer mucosa is more or less normal. There is no sign of inflammation in the midlayer, but there is only perforation of the eardrum. That to past tensa portion of the eardrum. So this perforation causes hard of hearing. So this patient will be happy the moment his hearing improves. So you give a hearing aid This patient is happy. Still, if the ear, usually what happens is, if the entire eardrum, the past sensor portion is lost, these patients will have only 40 decibel hearing loss. If the other ear is normal, they will be able to manage their life comfortably. So these patients may be allowed to go without treatment also. If at all you want to do surgery, what are the objective of the surgery? So you need to close the perforation. So our main objective of the surgery, if you are going to do, is you are going to close the perforation, and thereby you reduce the disability of hearing. And if the patient is having a symptom-free dry perforation, always think twice before doing surgery, because this could be a natural grommet. This opening can be serving the purpose of a natural grommet. So always avoid surgery in a patient who is having a symptom-free dry perforation. You would have identified, he would have come to you for a different complaint, and you would have identified the patient's perforation. Simply because you have identified the patient's perforation, don't go ahead and suggest surgery to him. So you should always give a patient the best, and he should benefit from it. So if the patient is having a dry perforation without any problem, you just advise them to wear a ear plug when they swim, in order to prevent reinfection. So what surgery you can do in these patients? If the patient insists on surgery, if you feel comfortable that this patient is going to get improvement of hearing when you do surgery, you go ahead and do surgery for these patients. So what surgery you can do? The aim of the surgeon is to close the perforation using graft. Ideal graft is a temporal fascial graft, and this surgical procedure is known as meringoplasty, and the commonly used technique is underlay technique. You use temporal fascia. Why you use temporal fascia? The temporal fascia is available in abundance close to the area of surgery, and its thickness is more or less similar to that of the eardrum, and its basal metabolic rate is very, very low. So it is less demanding and it is more useful. And then if the ossicles are eroded, how will you know whether the ossicles are eroded? If the photoaudiometry shows the conductive hearing loss to be more than 60 decibel, definitely the patient is having ossicular erosion. So the common ossicle which is eroded is the long process ventricle, because of its precarious blood supply. So you go ahead and do ossiculoplasty in these patients. If the deafness is more than 60 decibels, you go ahead and do tympanoplasty. Tympanoplasty means it includes meningoplasty and ossiculoplasty. Now, how are you going to manage a patient with acute mucosal chronic otitis media? So your aim in managing these patients is to make a wet ear into dry one. So how are you going to do it? By instilling antibiotic ear drops. So if the perforation is large, these are the indications for antibiotic instillation. The perforation of the eardrum should be big, and mind you, then only the applied ear drops should be getting into the mid-ear cavity, and you are supposed to fill the entire external aortic canal with the ear drop, and then you apply tracheal pressure, intermittent tracheal pressure. So what happens is, when you apply intermittent tracheal pressure, you will be pumping the ear drops into the mid-ear cavity. So the ear drops finds its way to the mid-ear cavity by what you are called as displacement method. This method of application of tracheal pressure, intermittent tracheal pressure, is known as ointment instillation by displacement method. So what it displaces? It displaces the air from the middle ear cavity and takes the place of air in the middle ear cavity. So it enters the middle ear and tries to combat the infection. But what happens is, you will have to think twice before using ear drops in chronically infected ear. So in chronically infected ear, the vascularity of the middle ear cavity is compromised. The vascularity of the middle ear is compromised, the entire area will be fibrous. So there is nothing to get repaired. So even systemic antibiotics won't help these patients, because it won't reach the middle ear cavity in adequate concentration. So these patients will have to undergo surgery. So cortical mastectomy is one way to do it. So you do a cortical mastectomy, you remove all the infected cells and clean up the entire area. So that is the indication for surgery is middle ear infection which is refractive to the antibiotic therapy. Inactive squamosal, again, you need not worry too much of the ear, but you need to look into the cause of the negative pressure in the middle ear cavity. So you need to treat the cause of the negative pressure. So what could be the cause of negative pressure? In a child, it can be adenotonsillar enlargement. So in adult, it can be sinusitis. It can be deviated nasal septum. You need to identify the causative factor for the prolonged cause of negative middle ear pressure and address it. So if you are not able to identify the cause, you can go ahead and insert a ventilation tube known as grommet insertion. I have simply included the lateral sinus thrombosis management because this is one complication of the chronic otitis media. This is actually commonly asked as short notes in your university examination. This is actually a little bit rare but extremely serious complication. The infection actually spreads to the lateral sinus from the mastoid cavity via venous channels. But prior to the formation of thrombus, perisinus abscess forms. And after the perisinus abscess forms, the entire lumen of the lateral sinus gets thrombosed. So these patients will have classically present with Pickett-Fence type of fever. What exactly you mean by Pickett-Fence type of fever? Pickett-Fence type of fever is unique for lateral sinus thrombosis. Here the fever will peak, come down, but it won't touch the normal. So when you look into the fever chart, it will appear like a Pickett-Fence. So it will go up, it will come down, it won't touch normal, again it will go up. So these patients, these children, commonly occurs in children, these children are drowsy, these children are lethargic, and on fundus examination, papilledema can be seen. And mind you, contrast CT or MRI is really diagnostic, and these patients should be taken up for surgery. Mastectomy should be performed, the lateral sinus should be decompressed, should be opened, and then anticoagulant should be administered post-operatively. Now, active squamous chronic otitis media, if the patient is not fit for surgery, it's an absolute indication for surgery. If the patient is not fit for surgery, you can ask the patient to come to your OPD on repeated occasions and monthly intervals so that you can perform suction clearance of the cholesteatomatous flakes. And then if you want to give cure, a conservative surgical procedure could be atticotomy. You remove just the outer attic wall, you scoop out all the cholesteatomatous material from the attic region and then make it into a self-cleaning cavity. If the cholesteatoma is extensive, you can go ahead and do a canal wall down mastectomy. The aim of canal wall down mastectomy is to eradicate the disease, to make the ear a self-cleaning ear and make it epithelialized. And then you want to maintain the hearing at the pre-surgical level or improve the hearing if possible. Now, how are you going to manage labyrinthitis and facial palsy? If the patient is going to have facial palsy as a sequel to active COM, it should be immediately addressed and the patient should be taken up for surgery under cover of antibiotics. So cortical mastectomy should be done, the disease process should be removed or cleared, and then the entire fallopian tube should be drilled out, and the entire section of the nerve, both the tympanic and mastoid and up to the labyrinthine segment, the bone, fallopian canal should be exposed and allowed a naked facial nerve to prolapse into the middle ear cavity so that it will have space to expand. The edematous facial nerve needs space to expand. The moment it gets space to expand, the function of the facial nerve also recovers. So the earlier you perform the surgery, better is the result. So intracranial complications of chronic otitis media is actually multi-specialty management. You need to administer patient antibiotics. You need to keep the patient under neurosurgeon's observation, and after clearance from the neurosurgeon, you can go ahead and do mastectomy. And acute labyrinthitis How are you going to manage? You put the patient on absolute bed rest. You can put the patient on IV antibiotics and then antiemetics and labyrinthine sedatives like chlorperazine can be administered, and mastered exploration can be proceeded with after the general condition of the patient improves. So while you do the surgery, you leave the cholesteatoma matrix over the fistula, over the labyrinthine fistula. You don't touch the cholesteatoma matrix immediately. So you clear the entire mastoid cavity as well as the medulla of the cholesteatoma matrix and come to the fistula portion later, so that any infection should not spread. The moment you peel the cholesteatoma, infection will get into the ear. So as soon as you peel the cholesteatoma as a last result, then seal the opening with a temporalis fascia graft. Now I am going to show you some of the resources I am going to give you. Here I will be projecting this QR code. This is actually ENT prep is an undergraduate book, e-book. All you got to do is use your QR reader of your Android phone. Just focus it. It will take you to the Android store, Play Store, and it will install the app for you. I will leave it open for some time for people who want to scan the QR code. This is a UG resource. This is a PG resource. Hello. Yeah, I will answer now. I will answer right now. This is the QR code for instruments. So I am answering all the questions Kiran has given me in WhatsApp. Hello? Oh, sure, sure. Okay, okay. So here, one of the audience has asked, attic area is above the eardrum, then how come it is covered by diaphragmatic eardrum? So this attic area is above the pars tensa portion of the eardrum. So mind you, the lateral wall of the attic is still the eardrum, and this eardrum is unique because it lacks the middle fibrous layer. And then there is another question which says, can there be only nasal allergy without bronchial asthma? If so, then the monocytes for the allergen are present only in the nose. It is very much possible a nasal allergy can occur without bronchial asthma, and allergy can be confined only to the nasal cavity. And mind you, all asthmatics need not have allergic rhinitis, and all patients with allergic rhinitis need not have bronchial asthma. There is only one condition where both these things coexist, along with hypersensitivity to allergic reaction to aspirin. So these patients who are allergic to aspirin are prone for allergic rhinitis in along with bronchial asthma. Cholesteatoma, being a cystic, again is a misnomer. It is actually a sac which is lined by squamous epithelium. So since it appears whitish in color, they termed it cystic by definition, but it is not a cyst, it's a misnomer. And then congenital cholesteatoma, I have already told you, the cholesteatoma can never be congenital for simple reason. Cholesteatoma always comes from the squamous lining of the tympanic membrane. The squamous lining of the external aortic canal has got no role to play in the pathogenesis of cholesteatoma. So what happens is the squamous lining of the eardrum can proliferate and get into the midlayer cavity and form cholesteatoma. So when the medial portion of the eardrum, when it proliferates and get into the midlayer cavity, the outer surface will be intact. So these patients can have a cholesteatoma in the presence of an intact eardrum. So the term congenital cholesteatoma is again slowly finding its way out. The next question is there any specific reason for progression of cholesteatoma from the posterior superior quadrant to the mastoid and not towards the eustachian tube? Actually, what happens is the attic or the epitympanum and the mesotympanum are separated by a tympanic diaphragm. I don't know how many of you know about it. What happens is the attic is separated from the mesotympanum by a fibrous diaphragm, and this diaphragm has only two openings, the anterior opening and the posterior opening. So cholesteatoma when it has got to travel to the mesotympanum, it has to breach this diaphragm, whereas attic and Otitis, they don't have this what do you call the safety wall. So what happens is it is easy for the cholesteatoma to spread into the attic, into the mastoid cavity, because that is the area of least resistance. Viruses are known to attack hair cells because they are all neurotropic viruses. So almost all these viruses affecting inner ear are all neurotropic viruses, and they have a sensitivity and preponderance to affect the outer hair cells of the cochlea. And mind you, the PG book can be installed. All you got to do is you got to scan the QR code. Be patient; it will take you to the Play Store. I am running it with my Android. Maybe you are using iPhone. If you are using iPhone, it will give you say it is incompatible. If you are using Android phone, you will be able to install it. Thank you very much for your patient listening. Any doubts, you can mail me. No problem. I will be happy to clear all your doubts via email also. Thank you so much.